So good morning, everybody, and thank you for being with us once again at these community chats from Montefiore Nyack Hospital. I am your host, Sandra Arevalo, and I'm the Director of Community Health and Wellness. Today, we're going to be talking about common hand conditions. Pretty much, if your hand hurts, what is it that we need to do? So in order to talk about this, we have with us a specialist, of course. He's really putting a lot of his time into this just to help us here because he's in between surgeries, believe it or not. So Dr. Alan Gottesman, he's here with us today. And we welcome all of your questions. So please don't forget to ask your questions. Dr. Gottesman is going to be doing a short presentation. So please write all your questions using the Q&A or the chat and write them down. I'm gonna read them to Dr. Gottesman at the end of his presentation. So without further ado, Dr. Gottesman, thank you so much for being with us today. I know that you're really doing an effort to be here. It's a busy day for you, like every day, I know.
Yep.
But a lot of people are very interested on these hand conditions because sometimes we have this pain, this chronic pain, and we don't know what to do. So why don't you tell us a little bit about yourself, how you got into this field, and let's get started there.
Sure. Well, thank you for having me. Thank you for everybody participating. My name is Alan Gottesman. I'm an orthopedic surgeon with a fellowship training in hand surgery. I finished my residency back in 2010 and subsequently did a fellowship in hand surgery out in Stony Brook, Long Island. So I pretty much focus most of my practice on the upper extremity from the shoulder down. I still do some general orthopedics, but most of the things I treat surgically are in the upper extremity. I personally find it to be pretty fascinating, very wide variety of conditions, and really have the ability to help people to be able to get back to very good function with their hands. And I think people really can appreciate it when they don't have ability to use their hand and afterwards can do more with it. So a very rewarding field for me.
That's very nice to hear. And you just said something interesting to me, how your specialty is from the shoulder down. And we've had a few orthopedists actually joining our community chats, and I see that pretty much everybody has their own specialty. So I can't wait to hear about the hand, and I guess maybe we can touch on the elbow a little bit, or maybe that's for another time. But that just got interesting. So yeah, if you want to start your presentation, go ahead.
Sure. So there's a lot of hand conditions out there. So I kind of try to pick the 6 or 7 that I would say are the most common that are out in the community, as well as ones that I treat. And I think there are ones that probably most people, unfortunately, will encounter at some point during their lifetime. So hopefully this is going to be helpful to just kind of have people an idea of what exactly they hopefully won't have to deal with, but if they do encounter them, they can get an idea of what exactly is going on. So I think, some of the ones that we tend to see pretty commonly are carpal tunnel syndrome. I think a lot of us have heard about that, although a lot of people do come to me and they kind of lump that together with almost every hand problem, but it is pretty specific things that carpal tunnel syndrome is encompassing, and we'll talk more details about them. Trigger fingers, also a very common problem. Inflammation of the tendons that we see. Arthritis, which many people are familiar with, a specific form called basal joint arthritis, which happens at the base of the thumb, can be quite disabling in many people. Ganglion cysts, these little lumps and bumps that people also will sometimes come up and not sure what it is. You get a little bit worried, but nothing that really is too bad, but good to know that it's nothing that you have to worry about. A different type of a tendinitis called Dequervains Tendinitis. Mucus cysts, so these little cysts in the tips of the fingers, and something else called Dupuytrens, which we'll talk a little more details of exactly what this is. So I would say these problems over here can encompass probably maybe 60–70% of the common things that we see on a daily basis. Then there's going to be many other conditions that are a little bit less common, but a lot of them will have also multiple people will have the same issues in different hands as well as different fingers. So this is something that we definitely can have this combination of these problems as well in people at the same time causing all kinds of different issues. So we'll start with carpal tunnel syndrome. So it's a very specific what it is. It's basically a pressure inside what's called the carpal tunnel, and there's a nerve in there called the median nerve. This is inside the wrist, and essentially when this happens, this extra pressure can cause significant symptoms on the nerve. The pressure comes from swelling of the actual contents of the carpal tunnel, which is composed mostly of tendons. So even though the nerve is what people are feeling as far as the pain goes, the actual problem is the swelling of the tendons, which is pinching the nerve. So we don't typically do anything about the swelling of the tendons directly. We just try to almost accommodate for those swelling tendons to diminish the amount of pressure on the nerve. The exact cause of carpal tunnel syndrome is really unknown to most people. A lot of people always think, oh, it's from typing, it's from writing, it's from things of that nature, repetitive motions. Those are certainly things that could aggravate carpal tunnel. As far as being the root cause, that's a little bit more questionable. So this is something that people who have the wrist in somewhat extreme position and doing it over and over, if they have carpal tunnel already, it'll definitely make it worse. But hard to say if that's exactly what's causing it. There are some specific conditions that we can identify sometimes that cause it, but the vast majority is just something that unfortunately people are predisposed to. So as far as the carpal tunnel itself, this is a diagram here of what the hand looks like. There's this little area here is the carpal tunnel, and that little yellow structure is what's called the median nerve, and that's really what's causing the pain. So in a normal hand, the nerve runs through this tunnel with no inflammation around the tendons, and it's not being compressed. When you have a lot of inflammation, which is being indicated by this redness over here from the tendons, that will secondarily compress the nerve, and that's when people begin to have problems. And as far as actual symptoms go, they'll start to cause numbness and tingling. Very common for people to have worse pain at night, especially because they tend to bend their wrist in extreme positions. That puts extra pressure in the carpal tunnel, causing the nerve to be further compressed. People will wake up at night, many times they'll say they have to shake their hand off, hold it over the side of the bed. Very, very classic symptoms what people have when they do exhibit these carpal tunnel syndrome symptoms. They can also feel like their fingers are swollen or fuzzy, and in the more severe cases, that's all the time. In the lesser severe cases, it comes and goes. People will also lose their fine sensation in their fingers, so they tend to drop items. They have trouble with buttons and clasps. Very weak pinch that can happen also from some weakness of the muscles, which can happen in extreme cases. They can have discomfort, obviously, which is very frequently the main reason people are coming to the office. And the diagnosis can be confirmed with special testing called EMGs, which are actually not so much fun. They got to shock the nerve and measure this, how much it's conducting. So not the most pleasant test, but that can confirm the diagnosis. So treatments for the carpal tunnel, initially when it's in the relatively earlier phases, we can try to diminish the swelling around the tendons, and we can use some oral anti-inflammatory medicine. Sometimes a steroid injection can help also, but that tends to be somewhat of a temporizing measure. Wrist splints, keeping the wrist in a straight position, not letting it get into those extreme positions where it compresses the nerve, can be helpful as well. But many people who come to me in more advanced cases will require surgery. And what the surgery is releasing that ligament that we talked about, which is forming the roof of the carpal tunnel. And we essentially open up that tunnel and relieve the pressure on the nerve. So even if the tendons are swollen, with the tunnel being opened, it no longer will compress it, and it'll relieve the symptoms. And many times the symptoms are relieved almost immediately. I have patients many times that tell me they haven't gotten a good night's sleep for months. The night of surgery was the first good night of sleep. So it can be very dramatic in some people how quickly that symptoms are relieved. There are two ways that the surgery can be performed: either an open technique, which is the more classic one, and then there's an endoscopic technique, which is what I personally do. It's a minimally invasive technique where we open up the ligament using a camera. So here's just a demonstration of the different techniques. The open release is with a classic incision, and right over there is the transverse carpal ligament that we said is forming the roof of the carpal tunnel, and that gets cut open. It can be done with a camera, either with one incision or with two incisions. You can see, obviously, these are much less invasive techniques than this one, only having to make a couple of small cuts over there. Both are equally effective, but the surgery does tend to be a little bit of a quicker recovery with the minimally invasive techniques. So one of the next common problems we see are trigger fingers. And essentially what a trigger finger is you have a tendon that runs all the way from the finger, going all the way down into the wrist and the forearm area. There are these core-like structures, and they would allow us to actually bend our finger. When the muscles contract, they will pull in the tendon, making the finger come down. Each of the tendons run through a tunnel inside the finger over here, and it's called a tendon sheath. The tendon sheath is composed of multiple pulleys. So if you look at them, there's 5 distinct pulleys. It goes from 1 to 5, 1, 2, 3, 4, 5. And the first one, called the A1 pulley, located right in the palm area, is where the problem tends to be with the trigger finger. What happens is it gets inflamed and it gets stuck in there, causing there to be issues. So the tendon can actually enlarge, which will cause it not to glide through that little tunnel easily, or the actual tunnel itself can get thicker and doesn't allow the tendon to go through that way. In either case, though, you have a mismatch with the tendon running through the tunnel, which is not letting it glide, and that can cause pain. It can cause triggering, where the finger gets stuck and pops open. It can cause a lot of tenderness right in the spot, and some people will not even be able to make a fist. So those are kind of the classic symptoms: the tenderness right at the base of the finger over here, catching, popping, difficulty straightening it out, tightness, bending it. And here's a picture of what that looks like. So you can see in this example here is where the tendon is actually thickened. You have a little nodule, and right over there is that pulley. That's the A1 pulley that we were just talking about. And the tendon is not able to glide properly through there. And this is one that actually is triggering, but some people are so bad they can't even get their finger down to get to the point that they trigger. So initial treatments are going to be focused on trying to relieve some of that pressure over there by splinting it, trying to let the inflammation come down, taking some anti-inflammatory medications. Once symptoms are going on for more than typically 4 to 6 weeks, I do offer people a steroid injection, and that actually tends to work pretty well for most people. Hand therapy has some benefits to try to work on the mobility, but I don't find that it typically will completely alleviate the symptoms. And ultimately, if this is a problem that continues despite all these lesser invasive treatments, we could do what's called a trigger finger release. Here's a demonstration of that. So right over there is a little nodule, not letting it go through. So this is showing how that's snapping. So we make a little cut over here, and that's the A1 pulley that gets opened up there. Okay, so next common problem that we see is arthritis. Now, what is arthritis? Arthritis is what we call a degenerative type of a process for most people, where the cartilage starts to wear down, and as the cartilage wears down, you have bone rubbing up against bone. And this is something that typically happens as we get older, and it's very common to see in multiple joints. The hand, we see it also in many joints, but the one that we typically see as being the most symptomatic is what's called the basal joint, which is the base of the thumb. So you can see right over here, this is the thumb. There's actually 3 bones in the thumb. There's 2 bones in the finger, and then the bone that attaches the finger to the hand, called the metacarpal. So right over here is where we typically find our arthritis in the basal joint arthritis. It's an area of high stress. Every time we pinch or grip, whatever force gets applied to the tip of the thumb actually gets transmitted 600% to the base of the thumb. So it's a very high stress area, and it's very prone to getting arthritis. I do see people having a significant genetic predisposition. It seems to run in females and families very frequently as well. So a lot of people will either have mothers or sisters with this type of a problem. But we definitely see it across the spectrum. I also do tend to find that people get this at an earlier age. Typically, people think of arthritis as happening once we get into our 70s, 80s, but I see people as young as 40 years old already developing these issues. So it starts off with some swelling, stiffness, discomfort right at the base of the thumb in this area over here. People can have significant diminished strength because of the fact that it hurts when they pinch. They have less motion. They're unable to get the thumb to go all the way down over here. And many people will also have a big lump over here. Some people who have arthritis won't even have pain. They'll just come with a big bump and ask what that is. Why exactly some people have pain and why some don't, that's not clear either. The X-rays can confirm the diagnosis. Most of the time, it's pretty obvious, just an examination. You can actually feel the bones grinding and rubbing up against each other. The treatment's initially going to be bracing, having a support. So this is a specific brace I typically recommend for people. It really gives good support to the base of the thumb, but it also doesn't really limit people's mobility. It's made by a company called 3PP. So I find this one to be kind of that balance of letting people still be able to use their hand, but giving enough support that it doesn't hurt them as much. And as well as, the other condition that we treat, anti-inflammatories can help, but not going to be a fix for the problem long-term. Same thing with steroid injections. They can help, but they are going to be more of a short-term fix. The only definitive treatment for this, if it gets to the point where it's really disabling, would be a surgical reconstruction where you actually remove the bone. And here is a demonstration of one of the techniques. There's a couple different ways of how we do this procedure, but the basics are very similar. This is that thumb metacarpal that we spoke about that connects the finger to the hand. And essentially, you see this big empty space over here. That's after the bone has been removed. So we typically will take that bone out and then do some sort of a reconstruction where we connect the thumb to the index finger to maintain that space over there so that we don't have bones grinding up against the bones. There's been a lot of different types of modification of the procedures over the years, but this procedure itself, which was originally described maybe 50 or 60 years ago, the basics have stayed the same. And this procedure works very, very well. It is a little bit of a recovery process, but people tend to do very well long-term here. So ganglion cysts, these are one of these kinds of things where most people who come in to see me for this, they just see there's some sort of a lump or bump. It's something that tends to be round, oval. They're filled with this jelly-like fluid. Typically, we don't have a history of any injuries or anything else. It just kind of creep up. And I see it on all spectrums as far as age goes. I've seen little kids with it, 2, 3-year-olds. I've seen people in their 80s and 90s. So really something that kind of affects everybody, that can affect everybody. The most, I would say crucial thing people come in is they're not concerned that it's something cancerous. So these are not cancerous. They have no potential to become cancerous. They're typically found on the top of the wrist, but they can be in other areas as well. So here's a couple different locations where we see them. This is the most common one on the top of the wrist. You can see them on the finger. That's called a retinacular cyst. You can see them on the bottom of the wrist over here. That's called a volar cyst. They're all basically going to be the same thing, though, which is going to be this jelly-like fluid that's going to be something that is firmly encapsulated, and it's something that typically doesn't hurt, but it can be annoying for people. So signs and symptoms, typically, again, they're painless. They just are there. People are concerned what they are. If they're really large, they can give some discomfort just because people can't bend their wrist. It just kind of gets in the way. Most of the time, people are coming because they just have a concern that they have a lump over there. So initially, typically we'll drain these. Draining it firstly confirms the diagnosis to make sure it is just a cyst, because you can have other things there, but most of the time it's pretty obvious in physical exam. And if it comes back, which many times it does after drainage, they could be excised surgically, but that's only if it's going to be symptomatic. So another type of tendinitis that we typically see is going to be Dequervains tendinitis, and that's going to be more on the outer part of the wrist, right over the thumb area. So it's a little bit more towards the elbow than the pain that you typically see with what we discussed before with the arthritis. So usually it's pretty obvious on exam which of these problems we're talking about. The tendons run from the elbow all the way up into the thumb area. So many times symptoms are going to be interrelated with the thumb as well. And it happens when you have the same thing with the trigger finger. We have a tendon running through. You have a tunnel over here where the tendon is running through. So the same basic concept where you have inflammation, it gets stuck in the tunnel there, causing pain. Some cases you can even cause similar symptoms to trigger finger with click, but most of the time it's more painful. So people will feel the pain over the side of the wrist. The pain can be sudden, it can be gradual, it can start in the wrist, go up to the forearm. It's worse typically when people are doing maneuvers like that. So a lot of people have trouble lifting up a gallon of milk, lifting up a coffee cup, all that kind of maneuver. Anything like that will be definitely uncomfortable. Occasionally you can have catching, snapping. It can be difficult to move the thumb and the wrist. Sometimes people can even develop a little cyst over the area from where the compression is. So treatment initially will be focused again on bringing down inflammation, so splinting, anti-inflammatories. Many times a steroid injection will help. Therapy, again, similar to trigger finger, can maybe help a little bit with mobility, but usually won't get rid of the problem. And if symptoms continue, the surgical release can be performed where you actually open up the tunnel, similar to the trigger finger. Mucus cysts. So these are also like ganglion cysts. They're filled with jelly, but they're very specific location. You see them at the tip of the finger. Many times people will initially see a dermatologist for this, and then if there's something that they feel needs to be further addressed, they'll be referred to me to take care of it. They're caused by some underlying arthritis. So what happens is you get a little bit of arthritis to the finger, you get these little bone spurs, and then the fluid escapes, and that causes these little cysts to form around where the bone spur is. Most of the time we see it at the tip of the finger, but it can happen in other joints as well. So it's usually visible just underneath the skin. Sometimes because of the pressure of the cyst, it can actually thin the skin out, and it can even actually spontaneously open up and drain. And that's actually something that we sometimes worry about because that can cause other issues. If this is not something that is particularly uncomfortable. It can be treated like the ganglions where we just drain it and monitor it. But if it's something that does rupture, it is something that we typically by itself, without us doing anything, it's a little bit of a concern that it can get infected. So that's something that many times we'll recommend treating, because if an infection happens, it can lead to a lot of problems because that infection can travel all the way down to the joint. So X-ray can be done to confirm the bone spur. And draining the cyst, similar to the ganglion, you get this jelly-like fluid coming out, but it's something that should not be done at home. I've had patients who've actually stuck a needle in there multiple times, ended up getting an infection. That was very bad. They ended up being in the hospital with 6 weeks of intravenous antibiotics. Not something that we want to have those types of situations. So I do that in my office sterilely, and I typically don't do it multiple times. If it's something that bothers people, it could be surgically removed. And surgically removing it entails not just removing the cyst, but actually shaving down that bone spur to prevent the cyst from coming back. So last time we talked about Dupuytren. So this is a little bit of an interesting disease. I actually have a little bit of an interest in this because I trained with a doctor who actually invented the medication that's used to treat this. So we did spend a lot of time during my training on this particular disease. It's an abnormal thickening of what's called the fascia, which is right underneath the skin. Usually in a normal hand, you don't really see or feel the fascia. But what happens with Dupuytren is it gets thickened, and you can start to see these little bands and actual little nodules developing. Now, when that initially happens, it's not much of a problem. Some people will come to my office and say, well, what is this? And basically tell them it's Dupuytren's. Not much to worry about if it's just a little nodule or just a little, what we call a cord. But over time, it can actually cause the finger to curl down. Now, that doesn't happen to everybody, but it can happen. It does seem to have a very strong genetic component to it. Most of the people I see are of Northern European ancestry. It seems to be pretty rare in people of Asian or African descent. So some of the things that we see, again, this is not a painful condition, and in the initial phases is just a lump, but if it starts to curl the finger down, there'll be difficulty straightening it out. So people won't be able to put their hand flat down on the table. In fact, there's a physical exam maneuver called the tabletop test that basically is positive if people can get the hand all the way down. You'll have the nodules in the palm. Usually they don't hurt. Sometimes it can hurt initially when they first come up, but usually it doesn't hurt much after that. They can thicken, they can contract. You can actually see like little dimples in the skin forming, these pits or grooves. But again, they're not typically painful. So this is kind of what it looks like, and these are the different stages. So initially you might have a little bit of a nodule, a little bit of a pitting, then you could develop these little cords, almost like a rope, and then those can cause the fingers to contract as those ropes start to come down. It does typically affect the little and ring finger. Those are the two common fingers that we typically see this disease in. And historically, if you look at a lot of things in history, you'll see a lot of depictions of people that have this position, such as the Michelangelo, the Papal. Some of these are all things that are believed to be people who had Dupuytren's, and they were actually demonstrating that when they did some of these artwork pieces. So as far as treatment goes, in the early disease, not much to do for it. If it's painful, again, usually some anti-inflammatories, but it's typically not painful. It's more going to be monitoring it. And what I recommend when people come to me with no contracture, I just tell them once a month, put their hand flat down on the table. As long as they can get it flat, they're okay. If they can't get it flat down, that means they're developing a contracture. They should come in, and then we talk about treatment for that. Therapy could maybe help a little bit. For the most part, though, hasn't been shown to really correct anything, though. As far as treatment goes, so the mainstay of treatment as far as how I treat these, once there is a contracture, and this is a good demonstration, this is what a contracture looks like. This finger cannot get straighter the way it is right now because you have this cord that's physically holding it back. So we do what's called a Zyflex injection, and this is the injection that I was talking about, the doctor that I trained with who invented this. It's been FDA approved for approximately 10 years now, and this works very well. The injection is given directly into the cord, right, where you have that kind of rope. And what it does is it actually dissolves it and breaks it up. So it's a 2-day process. They come in the first day for the injection, they come back 48 hours later, and then we manually pop the cord and we straighten the finger out. And here's a good demonstration of the before and after. So this tends to work fairly well. There is a procedure called a needle aponeurotomy, where you actually take a needle and you basically just go back and forth and puncture the cord. Not something that I do, but it is advocated by some doctors. There's one very well-known doctor in Florida who has a center that pretty much does these. But I've had pretty good results with the Zyflex injection. That's my mainstay of treatment. Last option would be surgical, and that's something that is reserved, at least in my practice, for people who failed all the other types of treatments. Over here, we actually go in and take out nodule and take out the cord and straighten the finger out. So those are pretty much the common conditions that we see. Again, there are many other ones, but I kind of try to pick the most common ones, and hopefully that will be somewhat educational and help some people out.
Yes, definitely. Thank you so much. And as you said, some of them are very common. I feel like not all of them, but at least three of them I've seen, just in people regularly, which is, interesting. Now, we have two questions from the audience. So
Yes, I
one
do see
is,
the chat.
how,
I can address those. So I guess the first question
yeah.
from Nicole, how do you decide which method of surgery? So again, I have my practice. I do an endoscopic carpal tunnel. I do a 2-incision. That's the one I've been doing since I've been in practice. That's how we trained with. There are many doctors do open, many doctors do 1-incision. It's a preference and a training issue. I pretty much routinely do the 1-incision endoscopic, 2-incision endoscopic technique. The recovery I find to be quicker with the endoscopic technique. Usually I tell people about 4 weeks. The open one tends to be a little bit longer, more like 3 to 4 months. And I don't typically brace people or do therapy after the surgery. The other
And the other
question,
question is,
yeah.
are brace needed after surgery?
Yeah, typically not. Most of the time, no braces are needed after the surgery. And then we had a question from Andrea. Squeezing a ball with a trigger thumb, probably not. I mean, in fact, anything that puts pressure directly over the spot here is going to probably aggravate it. So, squeezing balls is good for strengthening, doesn't tend to do much as far as inflammatory conditions though. So for the most part, not something that I typically recommend having people do for any extended period of time, maybe after the treatment to get the strength back, but not to resolve the issue itself.
Is it important when you have one of these issues to go straight for surgery, or do you think that it's necessary to try other methods like the injections that you were talking about or therapy? What would be the right way to go about it?
I think the majority of the conditions I spoke about, we don't go for surgery right away. The only one I would say we do surgery right away is the more advanced carpal tunnel. But pretty much everything else, the trigger fingers, the cysts, almost all the other conditions I spoke about, we definitely try 3 to 4 months of conservative treatments with anti-inflammatories, bracing, injections. The vast majority of the conditions I talk about, we don't go straight for surgery unless the patient elects to. There are people that come to me that have already had some of those treatments, but for the most part, we will usually try conservative treatments first.
And are all these surgeries covered by insurance?
Yes, for the most part, these are very common surgeries, very well accepted surgeries. Nothing that really we have an issue as far as insurance goes if we do need to ever get to that point.
However, when you were doing your presentation, you said that, sometimes, okay, you can go for physical therapy and all of that, but you are going to end up having to have surgery. Is that the correct impression? Or, or sometimes, with injections or steroids, you can reverse the issue. What do you think?
So a little bit depends on which problem we're speaking about. The conditions such as the trigger finger, the Dequervains Tendinitis, those are inflammatory conditions. So those can be treated successfully, and many times they are, with cortisone injections, braces, and anti-inflammatories. But the more degenerative conditions, such as the arthritis, those are ones that are not going to be readily reversed with an injection, so they can give some temporary improvements. So most of the time, if it's severe enough symptoms, the definitive treatments for those would be more surgical.
What will be the right time to seek help? When we just start feeling pain, or when we see that the bone is out?
Yeah, I think, I always tell patients, it's always at any point where there's any concerns, I think that's the time to go ahead and have it evaluated. Many of these things, people are somewhat suffering needlessly because there are sometimes very simple solutions. And at the minimum, just knowing what it is and what can be offered. So I think at any point, if people are having any significant concerns or discomfort, it's worthwhile to go ahead and seek a consultation.
Are there any preventive measures that we can take for any of the conditions that you have listed today?
I think, we have to be reasonable with the activities, try not to be doing too much with overstressing ourselves, trying not to do a lot of repetitive motions, trying to keep ourselves in more ergonomic positions. I think all of these things can minimize some of these things. Unfortunately, some of them are going to be more genetic predispositions, but we could try to minimize these things by trying to take care of the positions and the activities that we're doing.
Okay. Well, thank you, Dr. Gutelsman. I know that you have to go back to surgery. So how do we contact you? I see the phone number is on the screen, 845-359-1877. If you just want to tell us a little bit about your practice.
Sure. So we recently became part of the Montefiore orthopedic practice. I have two offices. One is in Orangeburg and the other one is in Pomona. I'm there 3 days a week, and the other 2 days I'm operating. And you know, this is something that, again, if there's any concerns, I'm more than happy to see people, even if there's not much intervention to do. Just the education part many times will be beneficial for patients.
Well, thank you so much for your time today. I really appreciate it, and I'm sure that our participants do too. And thank you to all of our attendees for being with us today. I will see you next week. Thanks a lot.
Thank you
Have
for
a nice
having me.
Thursday.
Bye-bye.
Bye.